Dr. Amila Ratnayake, Dr. Amit Gupta, and Dr. Raj Menon.
Hi, thank you very much to the moderators for having moderated this wonderful webinar today. On behalf of the Asian Collaboration of Trauma, I thank both the moderators, and no doubt I thank all the esteemed speakers of the day. And I invite my colleagues, Dr. Raj Menon and Dr. Amila Ratnayake also to this open forum where we actually discuss all the 4 talks and the reactions therein by our eminent reactors, and also try to answer the pertinent questions which are raised by our participants of the webinar. So welcome all of you once again, and I would like all the speakers and my fellow colleagues of the open forum to open their and the reactors to open their cameras so that they're visible on the screen. Thank you so much. Once again, wonderful, a bouquet of lectures on starting from the global trauma care in terms of developing systems of care in trauma, which is again very, very difficult, easier said than done. We had Dr. Shalvi Gupta speaking on that from the University of Maryland. And what I liked was that when she said that it's extremely, extremely difficult to actually, it's easier to talk about trauma systems, but when you start actually developing them, especially in those areas where the policymakers do not have an idea about trauma care at all, it actually boils down to struggling and banging your head to a wall. She gave examples from Milan experiment and her own struggles in the global forum to start trauma registries, to start trauma systems. Thereafter, we had a wonderful lecture by Dr. Sudha Jayaraman, who talked about the trauma exploratory laparotony, especially in the context of damage control. A lot of questions were there on the chat, and we'll be discussing some of those questions again in this open forum. What I liked about Dr. Sudha's lecture was the non-technical pitfalls. I think that every trauma surgeon has to remember that there are certain pitfalls which are not technical in nature, but you just tend to forget them just because as surgeons you're hardwired to mend the anatomy and the clock is ticking, and you suddenly forget that the clock is ticking, and the pitfalls happen. Then we had a wonderful lecture on vascular, and especially with a focus on endovascular repairs. I would like Dr. Raj also to comment on Dr. Sharon's lecture, because he himself is also an eminent vascular surgeon. And finally, we had a wonderful exposition of the treatment of major burns, right from resuscitation to the newer concepts in wound coverage by Dr. Sharmila Dissanayake. So welcome all of you. I'll just start by probably rolling in one question on trauma care systems. Today's panel is there from a country which started the trauma care systems and probably is one of the most advanced trauma care systems in the world. We all have to learn a lot from them. But in a situation like Asia, especially regions which are not very economically developed, it is a challenge for us to develop systems. My own opinion is that we should start with education. I think that's the minimum we can do as trauma surgeon, is try to build up capacity, which also Dr. Shelby herself said that the first probably foray into developing a trauma care system is to educate our own surgeons and emergency physicians and also the policy makers. I would like to ask our eminent speakers, I think Dr. Shelby is not here, but Dr. Sharon and Dr. Sudha are here from the US, and also Dr. Sharmila, what their personal experiences have been into impressing the policymakers about the importance of trauma care systems. I can understand, I've worked in the US, so I do know that systems are not perfect everywhere, not even in the US. And you have to continuously, bang your head to the policymakers for more funds. What is one single takeaway from your side, which you would say that you would use that as an impression onto the policymakers? We'll start with Dr. Sudha.
Sure. Thank you so much, Dr. Gupta, for the opportunity to comment. A lot of my work has actually been in the East African country of Rwanda on trauma and emergency systems development. And there is a lot, not just of lack of understanding, but also turnover in governmental and policy leadership. So that's a real challenge to keep impressing upon them over and over again of the value of trauma and emergency systems. One of the things that I was able to do in that particular setting was to bring a number of people, including key policymakers, to the US, along with nurses and doctors and surgeons and emergency physicians and pre-hospital staff, so that collectively they could develop an understanding of what a reasonably well-functioning trauma and emergency system looked like, so that they can then go back and think about how their systems should work. I think that having that collective and understanding is really valuable.
Thank you, Dr. Sudha. Collective understanding, wonderful message there. Dr. Sharmila, your experiences in developing trauma care systems, maybe outside the US or within the US itself?
So I'll actually speak within the US. I do not have extensive experience outside of it. So I'm in Texas, and Texas actually has one of the best developed trauma systems in the country. It's extremely robust, and it is built on work of what we call different levels. So level 1 is the highest level, as it's intuitive, going down to level 4, which is basically just kind of bare minimum necessities to function. And what's key is that the level 4 provides some emergent stabilization, but then the quick transfer is probably what it is. And I'll tell you that a big part of the good outcomes in the United States are because we have a robust both ground and especially helicopter transport capacity, which is obviously an extremely high resource thing. And so, unfortunately, it's one of those problems that without that, I can tell you the system in my region will fall apart. I cover an area in my trauma center about 250 miles. So I have treated patients who were shot in a town 2.5 hours away. And if not for helicopters getting them to me very fast, there's no way those patients would live. And so it is hugely dependent on very rapid transport. And the thing with helicopters is in the busiest city, they can land on the rooftops. They are not
OKNOW.
So I do think it's important to understand that whenever you're trying to create a system, think about how the transport between the components is going to work.
Right. Right. So you lay foundations of public transport and also sort of pre-hospital care that is very important. Dr. Sharon, your views on that, then we'll come on to the Asian perspective.
Yes, I'm finally back on. I'm so sorry, guys.
Okay, Dr. Sharon, can you hear me?
I can hear you now. Can you hear me?
Right, we were discussing about trauma care systems and its development in the US and some of the views coming from the developed trauma care systems in the US. Any experience with developing or sort of expressing your concerns about trauma care systems where you work or in some other lower income places where you've worked?
Yeah, so a lot of the trauma places, as so eloquently put by some of those speakers, are in areas of what we call now air deprivation indexes or, very food deserts, like very, high need areas. And so you really want this high complex system, but that's in a place where the resources may be very limited and where the populations can be very, very complex and difficult. So what we, have experienced, especially we have a level 1. And we actually harvest a lot of our patients from a lot of Central California into Arizona, Nevada. A lot to say that we serve probably around 1.5 to 2 million people in the catchment area. So you run into very different demographic groups. You run into a very complex transportation system depending on what's going on in a regional geography. And I think that all plays into developing a very efficient trauma system, right? It's not a matter of just developing a trauma system, but it has to be a trauma system that meets the college metrics, that can serve the population. And sometimes that can be very individualized depending on the needs of that population. I'm not a trauma surgeon per se, so some of the details of this I defer to my more experienced colleagues. which is actually on the Zoom right next to me right now. She can probably, explain this a lot more. But, I see these people writing all these, metrics that are very, very pigeonholed and very, very kind of menu based. And I'm not always sure that that works, right? Even within just continental United States, our populations are so heterogeneous and our needs are so heterogeneous, So it's a very hard question, but I think we need to really know our people and know the people that we're serving.
Thank you, Dr. Sharon. I think I'd like to bring in some Asian perspective here, especially from Thailand. Is Dr. Osari with us? I've been to Thailand many times, and I think it's a myth to say that you need a lot of funds to develop a good trauma care system. I think it's more about the conceptual part of it. And the Konkan experience of Dr. Vitaya Chanbuchachai, I'm sure Dr. Osari must be knowing the Konkan experiment and the Konkan system there, which is again a WHO collaborative center for trauma systems research. You have done it in Thailand at a very low cost. It's more like conceptual thing, more like education. What have been your experiences, Dr. Osari, in Thailand in general and specifically in place you are working?
Hi, can you hear me?
Yep.
Yeah, actually I work in the south, but I copy a lot of experience from Konkan, which is in the northeast. So we don't have inclusive trauma system yet, but we try to use the trauma quality improvement program, such as the trauma registry and morbidity and mortality conference to implement in our institute. And after Konkan have done that for like 20 years, it showed that the mortality rate decreased. So it's use low cost, but it take long time to see the improvement.
Yeah, thank you, Dr. Osari. I think one of the key messages from Konkan's experiment and also thereafter the guidelines for trauma quality improvement came in was a small experiment to do quality improvement meetings in the trauma centers or multi, sort of disciplinary preventable death panel reviews, including those people who have been bringing in these patients from the pre-hospital care, being a part of the team. And I think small process changes can bring about great differences in mortalities. Dr. Amila, any comments from your side, from Sri Lanka or from the armed forces?
Yeah, I agree with you all that because in the Asia is somewhat to me is different from African countries regarding the trauma systems. We have got almost the system is established. What I see is the lack of connections. And we have got great education programs in the Asia, but we are a bit struggling with the establishing the trauma registries. But we have got a lot of sources for data. So I like to ask the panelists and the speakers, what are your experiences with, from in the third world setting, the LMI setting, how to get these sources into a actionable data, It may be difficult for us to get robust trauma registries as in the Western countries, but there may be some ways and means that we can extract data and take into the actionable process, such as MM meetings are great the source to find out where the death's happening, how can we prevent. So I would like to, especially Dr. Sudha, what experiences in this establishing trauma registries in low and middle income countries.
Yeah, thank you, Dr. Amila. So my colleagues in Rwanda and I have actually a few years ago set up the WHO's trauma registry across 6 of the main referral hospitals in the country through the Ministry of Health. And it was implemented in 2019, so it's about 6 months before the pandemic. But still, it's been successful in terms of the education, in terms of actually expansion to more hospitals. And what we're working on now is how to use that information reliably. And I encourage people to consider that. The WHO's registry is free and they offer the technical support. And they also offer a dashboard with key metrics and audit filters and things like that that are useful to do, because that's part of the biggest challenge is, not just collecting the data, but then where do you store the data and what do you do with the tech support? And then what do you do with analytics? All of those challenges the WHO has taken on. And so that's really useful. Now you have graphs that you can look at to say, what is the mortality in this hospital compared to that one overall? And I think that's useful for the Ministry of Health. We're just starting to dig into that information now. So that's one point to consider. The other one is back to the QI concepts. The WHO's QI program is more than a decade old. One of my colleagues, Katrine Gilliard, who's a trauma surgeon at UCLA, has updated those QI concepts from the WHO and has applied them in Cameroon through some lectures, and she's recently published a paper on that. We're using exactly that and several other programs in Rwanda virtually. Just in the last few months, we've developed an online training course because, as Dr. Gupta pointed out, sometimes it's those small things that you need to change that can make a big difference. But the hardest part is getting that multidisciplinary, interprofessional willingness to think about the problem, and also dealing with the hierarchy. Nurses don't always want to say, hey, the neurosurgeon did something wrong. And so addressing some of those cultural constraints are really important. So that's all I have to say about that.
Thank you, Dr. Sudha. We can talk about trauma systems the whole night, actually. But
the whole night.
I think we move on to the next talk, which is your talk, which generated a lot of questions and a lot of things in the chat box. Let's discuss that. Wonderful talk on trauma exploratory laparotomy. The one thing I liked, the point was situational awareness. I think situational awareness is something which all trauma surgeons should be trained in, apart from the surgical skills. Is to remember that you're working in a situation and that can change very, very quickly. And one read I must tell all my participants here is the Top Knife, the book called Top Knife. I think all surgeons should read that. It's like Top Gun of trauma surgeons. You should read that book, which will tell you a lot about situational awareness. Anyway, so one of the questions, one of the points in your talk which generated a lot of questions was the exploration of, or always remember to explore the lesser sac and see for the pancreatic injuries, which we often miss, or many of the younger surgeons would often miss. A question to Raj to generate some sort of question. So yes, is it imperative to explore the lesser sac according to you? And if yes, if you find something, would you go ahead and do something offhand, or would you just wait and drain?
Thanks for the question. And when you were giving your talk, I was so glad that I saw quite a few of my residents listening in, because it's so crucial as a procedure that they need to know, and the whole technique behind it. Coming specifically to lesser sac, to me, it's a quick snip to have a quick look. And at the most, I would leave a drain. Probably in the damage control setting, I can't see myself doing anything more. But it gives me a lot of preparation for my next relook. But whether I need to get anyone else together with me, what am I going to do next round, or investigations in interim. There was a good discussion about, do you really need to, since the drain is the only thing you're going to do, and if you're going to come back soon, does it make a difference? I think it really depends on how your center is set up. And especially if you're in a center where you have rotating surgeons on different rotas who maybe not be a different person doing the surgery, then sometimes you don't want to risk information loss as you go from one stage to the other. Actually, that leads me to a question back to you, Dr. Sudha, which was that the fact that with operative trauma becoming a lot less common, especially with IR and non-interventional strategies going on, how do we maintain proficiency in this, especially for the unique algorithmic thinking and the various situational awareness aspects that we need to maintain, and how do we get our residents better equipped to do this in the future?
That's a great question. I enjoyed the discussion and the chat. I agree with you. It entirely depends on the institution in terms of what what steps make sense, and certainly, of course, the patient. In terms of how do you keep these skills up, part of me, and Dr. Sharmila probably will also comment on this, the trauma volumes in the US have gone up so much in the last 2 years in our major cities that it's almost heartbreaking to see. So that just makes me a bit sad. But aside from that, I think having this kind of a forum, perhaps to discuss challenging cases would be a useful thing. And then mentorship and, new and novel ideas of, are there ways to do, the Google Glass kind of remote augmented reality type mentoring or things along those lines that maybe, some of the more junior folks have good ideas about. Why don't we think about it, really outside the box? Why do we need to actually, see it and do it and be there and not just learn from each other? So,
Yeah, thank you.
I'll pass on to Dr. Sharmila.
Yeah, this is such an interesting topic. It's actually one of my favorite things. Yeah, we don't have a problem with trauma volumes. My residents have plenty. We don't have that problem, but you're right. In a lot of other settings, there are. But I do want to address a few key points because I think it is so important, because that's situational awareness. I actually think, and this is like heresy, so I make it a hobby to topple over surgical sacred cows. And so here are some of the things that I actually teach my residents is that, we have to really make clear distinctions between penetrating trauma and blunt trauma. Because in blunt trauma, of course, ATLS and the other protocols, algorithmic thinking works great. I think it works well. In penetrating trauma, you don't have the time for that often. And so I actually teach CABH, which is circulation. So first, get IV, just give blood, breathing very quickly, really quick, no pneumo. And then where are the holes? I need to know where the holes are and where are the bullets. So I put X-ray plates, get quick films of the areas the holes are, line up the holes and go, okay, now I know what I might be dealing with. And based on that, based on the trajectory, based on the patient's stability, we'll often take those patients straight to the OR and actually bypass the ER. We call it a flyby. A lot of places call it direct to OR. So our algorithm is completely different. I can tell you it's taken a long time for me to train other people that we don't do the standard thing. I mean, when I first started, I stopped people from bringing C-collars on people who were shot in the abdomen and pelvis. I'm just like, no, everyone stop. Just do what I tell you to do, and we'll move this patient on. I promise you're not helping with a C-collar. If the bullet's in the neck, we're already done from the pelvis. So, I think it's that thinking. It's actually thinking, what are you doing and why? I do want to address the Lissa Sack question because, this is another of my favorite dogmas. I think two things. So one is that Dr. Raj mentioned damage control surgery, and I'll tell you, I think a lot of us in the US, and Dr. Sudha can probably comment on this too, is that we're moving a little away that. So the heydays of damage control were probably the last 2 decades, and more data is coming out that it does have some downsides. It is a life-saving. I do it quite frequently, so I'm not trying to say it's bad. We are publishing a multi-center study on bucket handle injuries, and I hope my collaborators won't mind me giving a sneak peek preview by submitting the abstract to EAST in a few days. But there's a hint that damage surgery in that setting might actually increase anastomotic leak, and this will hopefully get presented soon and published. And this is just one of many studies showing longer term downsides after you've saved their life in the damage control. So I think we just want to be a little conscious of that and use it if you need it, but leaving that abdomen open just seems like it causes some downsides that we don't fully appreciate yet.
Yeah, thank you, Dr. Sharmila. I think you were very right in saying that the treatment needs to be tailor-made also, just not following one set pattern is the answer to everything. I think, as I said, coming back to DCS was that I always say to my residents that detest that urge to do everything at one go. I think that's something which all surgeons should need to know, because ultimately they are surgeons. They need to mend the anatomy, and they feel that everything needs to be done in one go. So unless you have that mindset that you have to stop somewhere, your DCS would not be both ways. Not doing too much, not doing under. I think that to maintain that balance is much. Let's come on to Dr. Raj once again. It's your foray, vascular surgery. Dr. Sharon is here. Some comments and some questions to her.
Thanks so much. And again, thanks for sharing. I was just writing away questions of my own to you, which I'll probably have to reach out to you offline to go through as well. But a few top line topics that I wanted to just discuss with you, especially with the greater endovascular focus that we have these days for our patients. Where do you draw the line with kids and pediatric trauma and pediatric vascular injuries? Because this is an area where stenting and the use of those has traditionally not been as strong. And where do you draw the line? Actually?
Yeah, so it's funny that you bring that up because that's been a very big focus of the SBS and a lot of the vascular societies, right? Like in general, vascular management for children as a whole. As a whole, you hit the nail on the head. We don't like to stent for kids because stents don't grow and the kids will. And the traditional teaching has been if you have got a vascular injury that needs to be repaired, you need to do a good old-fashioned open approach. And if it's not something that needs to be urgent repaired or whatever the situation is, right? Is there a window of opportunity for them to get to a point, let's say, where they're adult size, adult, capacity, where you can give them a definitive, repair? The vascular literature has been very clear, right? Kids will get, let's say, a bypass, easily will need a repeat bypass in 10, 15 years. Even if the bypass is great, you've now got this arterialized, atrophic looking giant vein that's really not doing the job anymore. So you have to give very clear expectations, maybe not so much always to the kid who doesn't understand, but to the parents who are actually going to watch this evolve as the decades go on. And then know that when they're in their 20s, you're probably going to repeat and give them a more permanent definitive repair. So it's a really complex problem. Now, again, I focus on my last slide when people bug me about infections. It's like, you got to save the life. If at that moment something needs to be done, you get that kid off the table and you get that kid alive into the ICU, resuscitated, and come back to fight another day, right? And again, it's really just making sure the specialists are tied in because we know the data, right? But the minute we lose sight of that patient, then that's when people forget, the nuances of what we did. So I won't say I will completely never ever stent a kid, right? But that kid comes in and there's an aortic problem and there's a peripheral stent that's going to fit that teeny tiny aorta. You bet your money I'm going to save the kid first, and we'll come back and figure out the more definitive thing later. So.
Thank you. Yeah, I think that was very clear, and really it is such a case-based discussion when you're looking at the patient in front of you. That there's probably not one answer that fits all cases. Yeah. Another big vein, to forget the fun, is essentially what do you do with venous injuries? Actually, for the general audience here, what do you think are the venous injuries that you can just ligate, ignore, and which are the ones in particular that you would still try to fix in a damage control setting?
Yeah, so that's a really great question because it kind of popped up in the chat area a little bit, which is, in the iliocaval venous setting, right? Which is, think about abdominal injuries, something going on the iliacs and the cable systems, is that you have to keep in mind, majority of commercially available stents are not big enough for the venous system, right? Venous stents as a whole are not covered stents. Usually they are bare metal stents, so they're not really going to help in the areas of vascular injury, extravasation, etc. To really get the size you need for that type of repair, you're really looking at adaptation of the iliac extension limbs that we normally use for endovascular aortic surgery. And that's a different beast, right? You're talking different cannulation sizes, you're talking different deployment systems. So you have to keep that in mind that it's not a slam dunk as just a peripheral stent that you're sticking in. It's doable, and I've done it for a cable, injury associated with it, where it's very morbid to just go in because the old ways when I was still, a junior faculty in training was that we just ligated it, right? That was very standard, right? Get rid of the bleeding, ligate it, and move on to deal with the bigger issues, the ones that will actually kill you. But having a cable, interruption is quite morbid, as if the patient stays alive, right, and moves on. It can be quite morbid and very debilitating, and an increased, and a massive disruption into their lives, and it can be. So, people have moved on now with endovascular techniques to stent it. Now, the other thing is the axial subclavian system. Same issue. It's too big for the commercially available extremity stents, but those systems are not amenable usually for a iliac limb deployment, right? They're not designed to take on the iliac limbs. So there you have the crux of the problem. If you really have a central axial subclavian system, like an SVC even involvement, you're probably better off getting a good surgical approach. You're probably there for something anyway that's going on in there. Now it's just going to looking at the intraoperative possible complications or morbidities associated with trying to get at those venous systems. If you are super lucky somehow, maybe doing a large embolization, right? A large amplatzer plug, something giant, and just smash the whole thing down, maybe an option. But my experience is usually things are too messy by the time you're involved in that whole central venous system, like the upper ones, to really kind of get a good visualization. Mm-hmm. So venous injuries are hard, and you know the bleeding is not insignificant. Mm-hmm. So we've all been there, but those are the things that we have thought of in the vascular world to try to adapt. We just don't have good answers, right? Especially since you're doing things off of IFU now, yeah.
Thanks, Sharon. And perhaps just to round up, and given that the majority of the audience here are trauma surgeons who are not vascular surgeons as well, how much vascular repairs do you think the general surgeon should try to undertake in these kind of settings before sending them to a tertiary center? And are stents all they are made out to be? Are shunts all they are made out to be versus actually getting a good bit of prosthetic and stitching that in while they transfer out?
You know, that's a really good question, because that's a currently moving topic. I think a lot of trauma surgeons, especially if you go to the big centers like Harborview, if you look at UCLA Harbor itself, like those big trauma centers, a lot of the trauma surgeons are actually quite comfortable doing the initial diagnostic, angiography or something like that. Certainly, some of them are even skilled now at putting occlusive balloons up to temporize any form of bleeding. So it really depends where you are, and especially the experience of your trauma surgeons. The ones that are at Harborview and the ones that are, at UCLA Harbor, for example, they're doing their own repairs, right? They're doing their own arterial repairs. They're not going to actually do the bypass, but if it's a simple approximation, primary repair, they're doing it themselves. The question from the vascular surgeon side of you is, well, who's going to follow these patients? A vascular anything is a gift that keeps giving. And I think we have seen that borne out in many different forms of literature. Someone has to do the serial duplex surveillance, see the patient, management of antiplatelets, and I think it's unreasonable to have the trauma surgeon, be the ones responsible for that. They already have a ton of stuff that they need to do. And I think the answer to that is really good collaboration. And, I think it's completely reasonable. Bad trauma surgeon takes care of it. And the phone call next day to the vascular surgeon is like, hey, by the way, this happened. Can you see them in follow-up in clinic? Things like that. I don't see that as a dump. I don't see that as some sort of abuse of the system, because while they were fixing that, I was probably bypassing the embolized cold leg in the other room, right? We all have a role to play. And I think the answer is you need to do what's safe for the patient. If you're not comfortable, call the vascular surgeon. But if you are, the vascular surgeon is still not out of the picture, because someone has to do the long-term follow-up, right, from the vascular side for these patients.
Thank you.
Thanks very much.
Dr. Raj and Dr. Sharon. I think I need to bring back all of you to the Asian perspective. I'm sorry to do that, but at times, in Asia, leave aside trauma surgeons, you don't, vascular surgeons, you don't even have trauma surgeons, you just have general surgeons on the ground. So we would probably train them in basic vascular surgery, especially starting with peripheral vasculars, so that they don't have any scare of touching the vessels, because in classical general surgical training all over Asia, generally they would not, sort of meddle with the vessels. But as trauma surgeons, we do train our general surgeon residents also in very basic, vascular repairs, like you said, so that they become comfortable that in case they have to deal with it at a periphery, they can do that, and obviously then refer it to a bigger center where probably vascular surgeons are there. So it's absolutely complementary, as you said. There's no abuse of system. There's nothing like that, but it's for the patient finally. So I think some basic vascular surgical training should be there for general surgeons, especially in countries where vascular surgeons are not there in numbers.
And I think shunts can be part of this. I mean, that was mentioned, but I think
Yeah.
we shouldn't underestimate how helpful a shunt can be to get a patient from place A to place B, where someone like Dr. Sharon can do a complex repair and at least save that leg or whatever it is.
Absolutely. And finally, we come on to the final lecture of Dr. Sharmila. Indeed, a wonderful, explanation about major burns, and especially the type of burns they receive in Texas, and right from resuscitation issues to reconstructive issues, and what a trauma surgeon or a reconstructive surgeon has to face, especially when the initial part is over and then you left with those bad scars. And also a wonderful reaction by one of the leading plastic reconstructive surgeons from India, Dr. Sushma. Thank you, both of you, for a wonderful. We had a couple of questions in the Q&A box about the initial resuscitation and the management of hypernatremia. Any comments, Dr. Sharmila, on those questions?
Yeah, so it's interesting. So I mentioned in the talk that it used to be that colloids were kind of heresy, right? I mean, it was like it leaks in the early shock period. It's not good. Don't give colloids. And that's actually where, in the original early teachings, we used to do crystalloid for 24 hours, and you weren't allowed to touch albumin until before. Like most things, that's just surgical dogma, and it's yet another sacred cow that's fallen. And so it's just our thoughts there were. Now, is there capillary leakage from albumin? Yes, absolutely. I mean, I think if you do it scientifically, you'll show that. But does that have clinical significance? Apparently not, because everything else is leaking out too, right? So in these big burns, everything's leaking out. And so you can leak out crystalloid, you can leak out albumin. And interestingly, with the oncotic pressure, albumin seems to leak less in clinical situations. I mean, we are finding results with it. So a lot of us in major burn centers are shifting back toward colloid and then FFP as well. Now, FFP will not leak out, so arguably it's even better, but obviously it's an extremely expensive resource, and so we don't want to use it. And so that's a traditional teaching that is being upended like so many others. Thing about hyponatremia, great question. Yes, it is completely an issue in burn because they're losing water, right? I mean, that's essentially what they're losing is free water. And so they will get a major free water deficit, and you will start to see them get hyponatremia too. And so, and I'll tell you that resuscitating them with albumin will make that worse for sure. But that's fixable. So we can fix it in two ways. You can fix it with oral water solutions, or you can fix it with intravenous D5W is what we use, and either one will work. And so, we do check at least daily labs on these patients and adjust as needed. And it kind of goes back and forth because sometimes you can see burn patients in the early stages get hyponatremia too. Electrolyte derangement is huge in burns, very common. And so no matter what happens, we'll be following it. And so once you start to see problems, you do it. Hyponatremia doesn't worry me too much because we know from our traumatic brain injury patients that it's actually surprisingly well tolerated. What worries me much more is things like renal failure, hyperkalemia. Those are much bigger problems. And if you start to see those in your burn patients, you're starting to have some real problems. Hyponatremia, they'll almost all the big burns will have it for a period and then get better once you treat it.
Thank you, Dr. Sharmila. In fact, I just wanted to know, because acute wound coverage in burns or major soft tissue defects is a major concern for all of us. Just your views on a point which Dr. Sushma also raised about cadaveric skin bank or skin banks in general. What are your views for those type? Because, ultimately, whether it is an artificial skin or a skin temp and things like that, these are very costly affairs. Not really, sort of realistic for countries like India or LMIC countries. So skin banks are a viable option or alternatives to these. What your views on how development of skin bank are important?
I think you use what you have, right? So I'll tell you, cadaveric skin is actually quite expensive here in the United States as well, like most biologics tend to be, but absolutely. So the downside of sort of cadaveric skin or animal skin, pig skins, what used to be used in the United States most, is that it's usually temporary, it doesn't incorporate. Now it does to a little extent. And, if you remove the epidermis, you can actually have it incorporate for longer and buy you more time. So I think it's a great idea. And it's a traditional thing. It's what we've been used. You know, it was interesting. The BTM that we're using now was synthesized by Dr. John Greenwood in his lab in Adelaide. And it's a completely synthetic compound, which tells me that surely similar synthetic compounds can be created, you know, in highly scientific advanced places like India that do have quite a little long history of ingenuity. Wouldn't surprise me if a similar product couldn't be manufactured, because as a completely synthetic product that you don't have to store, you don't need refrigeration, it's portable, you could send all over the country. And I would encourage Dr. Sushma and other leaders in Burns in India to explore that, because having used biologics for most of my career, cadaver skin and pig skin mainly, I can tell you this, it just leaps better to use this synthetic product that nonetheless gets incorporated. And I would say that trying to develop and engineer similar products, similar scaffolding products would probably be a great investment in a country that, as she pointed out, suffers a significant load of burns. Tilapia skin was another biologic that was affordable, pioneered in several places. Brazil, I think, first published it, and now commercially available products are available for that as well. Iceland has made Kerasis, also a fish skin product. So there's lots of biologics. But I do think that if you can create a synthetic, much like BTM, I think for the low-income countries, that's actually a better solution. It doesn't require storage in any complex fashion.
Thank you. Any final comments from Dr. Sushma? And then probably we'll go on to close the
Yeah, Dr. Shamila, I do agree. We need to move on from cadaveric skin and other things to BTM. And you have given me a wonderful idea that I must collaborate with my technical guys, especially the people in the IITs, and they can definitely look upon it. And when other countries have done it, so we should also start progressing towards it. Yeah, thank you.
Well, thank you, everybody. I think we already overshot our time for Open Forum. Such a wonderful discussion with all of you. Thank you, all the speakers. Thank you, reactors. And thank you, my colleagues, Dr. Raj and Dr. Amila, for joining me in the Open Forum. Over to you, the moderators. I think we'll stop the Open Forum as for now and with the program. Thank you all once again.